buenos días. Muchas gracias a todos por estar acá. Bienvenidos al SOLACI-CACI 24. Un placer para mí compartir esta mesa con la doctora Gatielo y el doctor Lasave, y un honor tener esta transmisión en vivo desde Toulouse con el doctor Dumonteil y Tchetche. Un caso estructural como para arrancar el Congreso bien arriba, y una sesión en honor al doctor Cribier. Muchísimas gracias de nuevo, y le paso la palabra a la doctora Gatielo, pues estamos en 10 minutos transmitiendo.
Bueno, buenos días a todos. Invitamos a los que están atrás a venir para adelante. La idea es que la sesión sea muy interactiva. Va a haber un QR donde va a haber preguntas para reaccionar y responder en el transcurso de la sesión. Obviamente ustedes saben por qué el tributo a mi mentor, y la idea de empezar este congreso con Proeducar, con la parte educativa de SOLACI. Por eso vamos a arrancar con Leandro Lasave, que es el director de Proeducar para SOLACI desde hace muchos años, y que tiene la responsabilidad de poner un poco la agenda de los fellows y educar a los fellows en América Latina. Él nos va a hablar de la primera charla, así que ya se va acercando al podio, en relación a mentoría en cardiología intervencionista, que es un poco, me odia por esta charla, pero es un poco el lema de esta sesión, alrededor de qué es un mentor. Gracias, Leandro.
Buenos días. ¿Se puede poner la presentación? Muchas gracias, Carla, por la presentación. Muchas gracias por la invitación. Soy el director saliente del programa educativo de SOLACI. El director entrante es el doctor Nicolas y simplemente voy a hacer una reseña. El Proeducar es el programa educativo de SOLACI que desde hace más de 20 años se dedica a la educación médica continua de los intervencionistas en formación de Latinoamérica. Se inició con la idea y el entusiasmo de uno de nuestros mentores, del doctor Hugo Londero. El programa genera una transmisión y transferencia de conocimientos teóricos y prácticos que van desde los especialistas más destacados de Latinoamérica hacia los intervencionistas en formación. Esa transferencia de conocimiento y el rol crucial que juegan los mentores en este proceso es un aspecto fundamental, sobre todo en la cardiología intervencionista, ya que la cardiología intervencionista es una disciplina en constante evolución y la habilidad para transmitir y aplicar el conocimiento es esencial para obtener buenos resultados. Es una especialidad eminentemente práctica, por lo cual no solo es necesaria la transmisión de conceptos teóricos, sino también, y más importante aún, la transferencia de conocimientos técnicos, la experiencia clínica y la intuición personal. Se cumplen 30 años de SOLACI y debemos destacar a nuestros mentores en este proceso continuo de transmisión de conocimiento, pero más aún debemos estimular la generación de nuevos mentores para que puedan mantener esa llama encendida en el desarrollo integral de los intervencionistas en formación de Latinoamérica. El rol fundamental del mentor es transmitir su experiencia y sabiduría, el desarrollo de sus habilidades prácticas, el fomento del pensamiento crítico y también como modelo de conducta ética y profesional. Es por eso que la transferencia del conocimiento en cardiología intervencionista es un proceso dinámico y que involucra múltiples fuentes y estrategias, que debe ser democrática, generosa y cultural. Los mentores juegan aquí un papel esencial a facilitar este proceso, ofreciendo de guía, de apoyo y de un modelo de conducta. Su influencia va más allá de la simple transmisión de información, ya que contribuyen al desarrollo integral de los intervencionistas en formación y al avance continuo de nuestra especialidad. Y a eso vamos. Muchas gracias.
Muchísimas gracias, doctor Lasave. Bueno, nos acompañan un panel de expertos en esta ocasión. ¿Sí? Martín Girard, Helene Eltchaninoff, Matías Stegman, Aníbal Damonte, Juan Fernández, no vino el doctor, todavía no llegó. ¿Dónde está? Patrick Serruys, el doctor Serruys, estaba recién por acá. Y tenemos un QR ahora para hacer una reacción sobre las preguntas, y le voy a presentar a la doctora Gatielo.
Vamos a ver si funciona el primer QR de la mañana, un poco en torno de la primera pregunta. Va a haber preguntas que están preformuladas y tienen respuestas que ustedes van a tener que decir. Vamos a hacer el primer react, que es la primera pregunta. Le pedimos a la técnica, pedimos que todos escaneen ese QR y den la respuesta un poco a la primera pregunta, que es que si consideran importante tener un mentor en sus carreras. Un poco es de perogrullo, pero un poco la experiencia que han vivido ustedes como cardiólogos intervencionistas durante sus carreras. Esperemos que la técnica funcione y que el React dispare a medida que ustedes van escaneando y van respondiendo las respuestas. Y me gustaría saber, Leandro, ¿quién fue tu mentor?
Bueno, varios mentores. Tuve desde los inicios mi formación como cardiólogo clínico en el Instituto Cardiovascular de Rosario. Tengo que nombrar a todos prácticamente. Después en San Pablo, el doctor Eduardo Sousa, por supuesto, el doctor Alexandra Bisaí, el doctor Fausto Férez, y después vuelta a la Argentina, obviamente Aníbal y el doctor Eduardo Picabea, que fueron mis acomodadores después de la formación, ¿no?
Y Diego, vos, creo que tenemos alguien en común.
Tenemos una mentora en común, ¿sí? A Liliana, claramente, pero no tengo que dejar de nombrar al doctor Sarmiento, que fue durante mi residencia en el Hospital Francés quien también me apoyó muchísimo. Y después mi formación pura en cardiología intervencionista y en muchos aspectos más de la vida fuera de la cardiología intervencionista fue Liliana.
Mientras vemos ahí las respuestas de cómo es la perspectiva de tener un mentor en sus carreras, el 41% dijo que el mentor ayuda a tomar decisiones y a elegir un camino en la carrera. El 34% dijo que un mentor es como un padre, una madre, que es una figura medio paternalista en la carrera. Y el 24% dijo que un mentor enseña con ejemplos. Aun cuando no tenga habilidades blandas de mentor, ¿sí? Eso es algo que no nos enseñan en la facultad ni en la carrera, uno las va aprendiendo en el transcurso del camino. Así que, bueno, y nadie creyó que no necesita un mentor. Eso es muy bueno, ¿no? Porque todos, en algún momento de nuestra vida, necesitamos a alguien que nos enseñe, sobre todo esta especialidad que es tan manual.
Sobre todo eso, que es una especialidad muy práctica y muchas cosas que alguien puede enseñar en 15 o 20 minutos no se aprenden en ningún libro durante mucho tiempo, ¿no?
Sí, pero para mí el mentor no solamente tiene que enseñar las habilidades, ¿sí? de la hemodinamia, la parte práctica. Te tiene que dar una guía en toda la parte ética, ¿sí? Porque uno puede tener mucha habilidad práctica, pero si no tiene una conducta que se condice con su conducta en la vida, no vamos a llegar nunca a nada. Es una misma cosa, ¿sí? Tener la capacidad práctica y ética y la relación con el paciente. Eso es muy importante también. Y no todos los grandes te enseñan eso, tener la relación con el paciente, la parte humana.
A mí me gustaría, mientras tenemos estos minutitos antes de conectar con Toulouse, que levanten las manos quién tuvo un mentor adentro de América Latina. Perfecto. ¿Y quién tuvo mentores afuera de América Latina, que los tuvo que encontrar afuera? O sea, creo que el mensaje es, ya sea adentro o afuera, hoy es mucho más fácil con las conexiones y con las redes, encontrar el mentor en tu institución o afuera de tu institución. Creo que eso es un mensaje para la gente joven, que por ahí a veces tiene muchísima más velocidad para encontrar mentores afuera que nosotros en nuestra época, y eso es una ventaja, pero que es fundamental hoy en día con las redes y con la conectividad. Y creo que el cardiólogo intervencionista no es de Argentina, de Brasil, de Venezuela, es un médico global, o sea, porque básicamente una angioplastia se hace igual en todos lados del mundo, con más, menos material, con más o menos dispositivos o disponibilidad de cosas, pero la manualidad es muy parecida en todos lados, por lo cual nuestro objetivo es poder, como mentores de nuestras futuras generaciones, poder formar a ese cardiólogo intervencionista global que puede trabajar en cualquier lado del mundo. Creo que ese es un poco el mensaje.
Sí, y el que tuvo la suerte de tener un mentor es muy bueno que tenga la reciprocidad y enseñe a quienes tiene debajo, ¿sí? Porque eso va formando toda una cadena que va agrandando toda nuestra especialidad. Bueno, ya estamos, Carla, si querés, en un ratito para arrancar la transmisión.
Sí, creo que no sé si está Flavio, que nos faltó, pero está todavía no llegó, no importa. La idea es que el caso sea muy interactivo, vamos a ser muy rigurosos con el timing, vamos a ver si Toulouse ya está para conectarse. Como saben, Didier, Tchetche y Nicolas Dumonteil son dos cardiólogos intervencionistas muy conocidos, tienen muchísima velocidad para hacer un caso en vivo, por eso los pusimos en esta sesión, que el tiempo era ajustado. Queremos ver si nos escuchan y si nos ven, nosotros todavía no los estamos viendo. Nicolas.
Yes, yes.
Bonjour Nicolas,
we
bonjour
hear
Didier.
You, bonjour, bonjour. Buenos días a todos. Can you hear us also?
Yes, we have a simultaneous translation in English, translation to Spanish, so you can talk in English, because if we talk each other in French, only Helene and Martin, they are going to understand each other. So please present your case and your staff in the lab.
Yeah, thank you. We are very pleased to share with you how we're going to treat this patient today. And basically our objectives and what you will see during the next 40 minutes is a step-by-step transfemoral TAVI, the way we do it in Clinique Pasteur. So to start with that, the way we do it is with a limited and reduced team. It's what we call the streamlined TAVI. Two operators, to my right, Didier, Tchetche, you all know, and a nurse, scrubbing, Melody. And we have just behind us a circulating nurse who is helping us with a procedure. But regarding the staff in the room, that's it. But I think now what is the most interesting is for you to learn about the patient we're going to treat today. So Didier is going to give you a few informations.
Okay, sure. So it's a real pleasure to share with you this case. So today we're going to treat altogether 87 years old male gentleman, highly symptomatic with a dyspnea class 3 and NYHA. And you can see that that patient is not really, this patient is not really overweight, with a good quality of life. As main past medical history, noticeable is the prostatic cancer and some hematologic disorders. So as expected, the transthoracic echo revealed a significant aortic stenosis with a mean gradient of 50, an aortic valve area of 0.85, and the left ventricular ejection fraction is at the lower margin of the normal values, but it remains preserved. From the laboratory standpoint, you can see that the creatinine clearance is slightly decreased, 58 milliliters per minute. And on the ECG, you're going to see that that gentleman is in sinus rhythm with a left bundle branch block. And we also assessed the coronary arteries, as we do for every single patient with an aortic stenosis, and there weren't any coronary artery disease. So this is I guess the most important part of the assessment of the patient is the CT scan, CT scan screening and all the measurements that we do, starting from the aortic annulus. If we have a kind of broad overview of the anatomy, you can identify these chunk of calcium that may put the patient at higher risk of annular rupture if we apply too much of a sizing to this anatomy. And dimension-wise, the mean area-derived diameter as well as the mean perimeter-derived diameter of the aortic annulus was 24.7. And we have a tubular configuration. If you start from the aortic annulus and you scroll down to the LVOT, you have the same measurements, the same aspect, with that calcium chunk that goes alongside the left atrium and the mitral valve. So we're going to see how this may impact the final outcome. So we scroll a little bit upwards on top of the aortic annulus, and what we get is that asymmetric calcium distribution. You can see that mainly it's the tip of the non-coronary sinus, non-coronary leaflet that is highly calcified above the aortic annulus, and below, if you have a closer look on the left, bottom left picture, you can see how dense is that calcium and the extension within the LVOT. But overall, we have very large sinus of Valsalva and high coronary arteries, 16 millimeters on the left side and close to 20 millimeters on the right side. So at last, the peripheral vasculature assessment. We have decent diameters, on average 8 millimeters on both sides, mild tortuosity and mild calcium. Of note is that apheroma burden that extends, that protrudes within the abdominal aorta, but nothing that could prevent a safe advancement of a sheath, and then the delivery system. So this is what we have in terms of anatomy. And then if we, as we are planning a TAVI procedure, we need two views. One of that view is the contemporary one, the cusp overlap projection. And here it's a LAO6, caudal 24, based on the orientation of the ascending aorta of this patient. And the free cusp view is a LAO28, caudal 3. So usually the cusp overlap projection is more into a RAO caudal projection. So we are slightly offset based on the angle of the aortic annulus. So this is a strategy, Nico. What we have all decided here is to go through the femoral access, and Nico is going to describe what he did under conscious sedation with an ultrasound guided puncture. The closure strategy may be debated, but this is what we do here with a single prostyle as a pre-closure strategy. We're going to showcase during this live transmission how to use the left ventricular direct wire pacing and the valve based on the anatomy. And this could be discussed with, this has to be discussed with all our friends in the panel, is a balloon-expandable platform, keeping in mind that calcium chunks, so some may promote and recommend a self-expanding platform, but we have decided to use a balloon-expandable platform. And for the sake of to integrate the calcium, the risk of calcium, we have chosen a 24.5 millimeters Myval Octacor device, and we're going to pre-dilate. So this is what we have, Nico.
Yeah, thank you, Didier. Thank you, Didier. I think, and I hope you have now a clear understanding of the features of a patient we are going to treat. Just a few words about the setting on top of what Didier described. So the sheet is already in.
Sorry, Nicolas, Didier, Diego Greenfield here. Thank you very much for sharing your expertise with us. If you let me, I would like to introduce Dr. Matthias Stegman and ask him some considerations of the case and on the valve.
Hi.
Of course.
Hi, Nico and Didier. Good morning here. Good afternoon there. The first question is about the setting, because Didier talked about, or Nico, about the persons in the cath lab, and you do not mention anesthesiology. There are an anesthesiology in the room or not? This is the first question. And the second question is if you can talk about tips and tricks to try to avoid annulus rupture using this platform balloon-expandable valves, no? Thank you.
Yeah, thank you for the two important questions. Maybe, Didier, you will address that while I'm starting working.
Okay. So, what you should get on screen is the fluoro, méthonular fluoro. And so meanwhile, Nico is advancing the let's left one to cross. The first question about the anesthesiologist and the anesthetic support. What we have is a kind of wandering anesthesiologist. So our colleagues are always present within the cath labs, and they prepare the patients, they provide the conscious sedation medication, and then they go to another room. And this way, if we need them for any kind of emergency, they are available. So we do have the anesthesiologist, but they are not 100% present during the case. So this is what we do here. This may be different in other cath labs, so it's always interesting to share your philosophy. How is it in your cath labs?
Didier, if I may, I just interrupt you because you having an interesting discussion, but I think what we are seeing on screen also is very educational and interesting. You see that I started to cross, and you see where the pigtail here is in the non-coronary cusp, and I crossed here. But the wire is in the LV. But when I'm advancing here, you see this resistance and you see this trajectory of the catheter that is not usual.
Yeah.
So it's something I don't like. And usually when I have that, I prefer to go out and to try to recross in another location.
Yeah, it makes sense, Nico, because the risk of getting entrapped, entangled within that commissure is really high. And so trying to get access as you did, more in the commissure between the left and the right and the none is most important. So coming back to the anesthesiologist, Matthias.
Sorry.
Yeah.
Let me introduce to Aníbal Damonte, Dr. Aníbal Damonte.
Good morning, Didier. Good morning, Nicolas. It's great seeing you. And regarding maybe we go back later to the anesthesiologist's role and maybe also as the default puncher guided by ultrasound. But I have a comment or a question, because I would tend to treat these patients with this junk of calcium with self-expandable devices. But since the introduction of this new generation of balloon-expandable devices with intermediate sizes, I feel much more comfortable to use them, although there is a great amount of calcification at the annular size or junks of calcium like you showed. Maybe
exactly.
You will later comment on that.
Maybe you wanna explain why we did select the Myval Octacor and why this 24.5 could play a role.
Yeah. You're right. It's true that with this, the anatomy you've seen on the CT scan, there is a risk of mechanical complication with balloon-expandable platform, but we think that this risk is particularly here when you have an important oversizing. And the original feature of this device, as you know, is to offer intermediate sizes. So here we have a 24.7 annulus. We plan to implant a 24.5 device, meaning we don't have an important oversizing or at least no oversizing. And therefore, we hope to have reduced or don't have any kind of risk of mechanical complication. If we come back to what we're doing, Didier, and the case, what we would like is to show you of course, where we are now with crusts, but also the hemodynamic recording that you have. So we have through the valves. As expected, we have the gradient of this patient having a severe aortic stenosis. And what we saw also, Didier, is some transient episode of 3-degree AV block.
Yeah, exactly.
That happened, that are resolved now, but that happened as soon as I crossed. So we'll be prepared for potential 3rd-degree AV block later during the procedure.
Yeah, this is something that we have to keep in mind, because only with the contact of the catheter with the conduction system, you get that. So let's keep this in mind.
Yeah.
So the wire you're going to use is a Safari Small. Safari Small is the wire that we regularly use for our TAVI cases, which we try to get it as deep as we can in contact with the apex of the left ventricle. A nice
Nicolas?
Location in the outer curvature.
Yes.
Nicolas or Didier, I have a question for you. You have a special concern regarding the patient have a left bundle block and amount of calcium and LVOT. You consider any special things regarding the possibility of AV block?
Yeah, it's true that this patient is exposed maybe to a little higher risk of 3rd-degree AV block. It's not, I think, the same level of risk as the patients having a right bundle branch block, or who are for sure at much higher risk. And for those patients, for example, we start the procedure always with a venous access, and also most of the time with a temporary right ventricular pacing lead. Here, I would say the risk is a little bit lower, but it exists. So we have this in mind. The next step for us, considering the burden of calcium at the level of the valve, the next step for us is to pre-dilate, Didier, in order to make afterwards the crossing of the Octacor valve easier. But what you can see if you have now, again, Didier, the ECG under your eyes, what we can see is that we are currently at this step experiencing some transient episodes of third degree or second degree AV block.
Exactly.
So what about Didier now? Maybe putting a venous access and a right ventricular lead.
Yeah.
Because of course we can pace on the metallic wire in case we have third degree AV block, but we will have to make an exchange before to implant the valve, and it will be more comfortable for us if we have a right ventricular lead. So while I'm doing this, Didier, maybe I let you discuss the other points we had remaining.
So let me ask Didier and Nicolas here to Flavio Rivicini, who he's a big guy and have big experience in balloon-expandable devices. So first question, do you consider to put a pacemaker in this type of patient with a very tight aortic stenosis, and he has a problem when they cross so tight valve? First question. And what about sizing?
Thank you, Carla. Good morning, Didier and Nicolas.
Hi, Flavio.
Hello. Well, we normally pace through the wire, and in a case like this, we always put a femoral vein sheath. This is not to ask the anesthesiologist to do the job. They take much more time than we do. We are in the femoral, so we always take a venous access. In this case, I would pace on the wire, and in case of need, you can always put the temporary pacemaker. But we always do a puncture in the right or left femoral vein. And regarding the sizing, I think it's a very interesting concept that this valve provides you a very wide range of measures. But it is also true that we have been implanting the Edward valve for more than 12 years with these 4 sizes, and most of the times it fits very well. What I'd like to know from Didier while Nicolas is working is whether in this case you do pre-dilatation in case you would implant a SAPIEN valve. So does it, because I have no experience with the Myval, so my question is there a difference? Because I would go direct with the SAPIEN, you are going to pre-dilate.
Important comment, we're going to pre-dilate just for this case because we want to make sure that we get access easily across the valve, but usually for the vast majority of the patients, we don't pre-dilate.
Yeah.
We tend not to pre-dilate because it's not necessary. So for this patient, tu as 60, c'est bon?
Sorry, I would like to ask
usually
Helen,
we don't pre-dilate, but here we're going to pre-dilate exceptionally.
Helen, what percentage of pre-dilatation do you have with your patients?
Personally, I wouldn't pre-dilate because I think it's not heavily calcified. And I know that sometimes for several valves, like new self-expandable, Navitor, etc., the company asks the pre-dilatation. But for SAPIEN, we don't pre-dilate except very calcified.
Yeah, exactly. We do the same, Helene. And there is that trend to systematically use a self-expanding platform when there is calcium. And I have to say that I'm not sure that that's the best strategy. It's more about making sure that the device you're going to select is going to match the anatomy of your patient. And usually it's more about the technique. So we may use balloon-expandable platforms in heavily calcified anatomies. It's more about the way we deploy the devices. It has to be gradual. It has to be gentle. And we need to assess the degree of expansion of the stent frame and the degree of regurgitation that we get during at one point of the deployment to see if we fully apply the nominal volume of the balloon, or if we decrease, we withdraw a couple of milliliters. So I must say that I have kind of backed a little bit from this strategy of putting a self-expanding for calcified. It's more about trying to make sure that the valve size and whether it be the hemodynamics, the coronary access, all these other features are going to play a role because in contemporary practice, regurgitation is really an issue
Didier,
now.
I think Martin
device.
have some comments regarding this point. Martin?
Yes, hello Nicolas and Didier. Just
Hello.
very often in your center you use a cerebral protection. Here you make a predilatation and so on. So you don't use it for this case. Why? Have you an explanation or?
Yeah, Martin. As you know, we are missing data to support that on routine practice. So what we're doing is using that on very selected patients considered at very, very high risk of stroke or part of subgroups that have been identified at maybe higher risk, like bicuspid, like complex valve-in-valve. Here it's true that we have calcium, we predilate, but we consider it's still a routine case. So that's why we don't use it.
Thank you.
So let's proceed now, Didier. And sorry for the time. I had to put this leads. So we're going to predilate for a reason mentioned. On va tester la stimulation à 180. So it's a gentle. Okay, stop. It's okay, Didier. You're ready. It's a gentle predilatation. It's a 20 millimeter balloon. So pacing on. Okay. Okay.
What size of balloon is that? What size? What balloon size?
It's a 20 millimeter balloon. And the idea here is to have a gentle predilatation of a calcium and to make the crossing afterwards easier, as we mentioned. It's not to have a full preparation of a valve. And now we are ready, I think, Didier, and to proceed with a valve implantation.
So before we go, we do that. Maybe we can review the reference and geography.
Let me show that to you.
What we get.
Let me ask some questions to Dr. Juan Fernandez.
Yeah, of course.
Juan, what kind of valve do you prefer in patient like this? Balloon-expandable, self-expandable?
Yes. In the majority of the cases, I put a balloon-expandable. But my concern in the case is about the calcium. Do you prefer to predilate with which balloon? How do you select the balloon to predilate?
Okay, so maybe I can summarize that for you. Just about the predilatation, so we try to start with the minor axis of the annulus at baseline, just to make sure that we just open up a little bit the leaflets, make room for the valve, the device to get across the aortic annulus, but we are not too aggressive for that. So that's a rule of thumb. Start with the minor axis, the minimal diameter of the annulus. The second thing is that, as we said before, having that intermediate sizes of the Octacor, it's one of a very new and unique feature of that device, these intermediate sizes, and we are getting closer to a true sizing. That is to say that you use the valve that matches the average diameter of the annulus, and that's very elegant. So it minimizes the risk of annular rupture. There is a sealing cuff, so the risk of paravalvular regurgitation is not important. So that's one of the reasons why we can use with these new generation devices a balloon-expandable platform.
Didier, would you mind to very shortly describe the difference between this balloon-expandable device, Octacor new version, from the version that we use in Latin America, and the difference from the Sapien one?
Yeah, so exactly. So what we have, so Nico has inserted the inception sheath. That is a 14 French sheath that is can be then pre-dilated with an 18 French dilator, just to make sure that the valve is going to get across. And Nicolas is going to show you how the inception sheath expands, and it's very smooth introduction through the vessel, even when it is tortuous, and it's a very nice conduit for the device.
And Didier, just a remark here, considering this anatomy, we thought it was a nice strategy to work through a sheath to avoid stretching this apherma we saw at the level of the abdominal aorta.
That was another very important point. Then when it comes to the device, just to make it short, so this is a balloon expandable device with these octagonal cells that are slightly overlapped, and that's very, very elegant and unique in the sense that the device is going to expand with minimal foreshortening. So the 24.5, we could expand it furthermore. It's going to reach 25.1 maximum. So you see that it's really a true sizing. Nicolas just demonstrated what the landmarks that we have. So you see the proximal and distal markers of the balloon, and then we have a kind of asymmetrically distributed. We have a marker that is into the inflow portion of the stent, the device, the Octacor, and this is the positioning marker. And then we have a thin line that is the center of the balloon. So the most important landmark is the positioning marker, and that valve is preloaded, pre-mounted onto the balloon, so there is no additional maneuvers. The catheter is highly flexible, extremely flexible, as you can see. It's we can use it. Most of the time we don't use it, but it's deflectable, just to make sure that we match the anatomy of the aortic arch. So very, very unique features. And at last, during the preparation, but you are more familiar with that, I guess, the device was crimped in a way just to make sure that we maximize the chances of commissural alignment.
Yeah, but we'll check that afterwards. Let's cross the arc, Didier. So you have control of the wire.
Nicolas, I have another question. Yes. Do you always use CASO overlap for the implantation? Well, I mean, you change the views if you use a balloon-expandable, sex-expandable valve, or you always use CASO overlap?
Yeah, we make a pause just to answer to you in order not to wait with a valve inside the patient in the aortic valve. The answer is simple and yes for all the platform. Each time it's physically possible. I mean, each time the cusp overlap predicted projection is comfortable to work with, we use that for valve deployment, whatever platform, balloon expandable, self-expandable.
Exactly. So it's a more contemporary way.
Yeah. So let's go, Didier.
So we didn't flex at all the device. It's been pre-dilated, and you can see how nice
crossing is nice.
Did you feel a lot of frictions? Or?
No,
nothing.
Actually, nothing. So what I'm going to do now is just to ensure that I have a good support with my wire on the left ventricle, doing this with my right hand.
And the deep implantation, do you recommend with the Octacor is 80-20, 10-90?
It's more about the marker, and you see the idea is to put the marker at the annulus. If you want a high position, you can put it exactly at the annulus. If you want a slightly deeper position, you can put it just below the aortic annulus.
The point, Didier, is that what we see here would be more or less the position of the valve once deployed. In other words, we don't expect to have a lot of foreshortening, especially in the inflow LVOT portion of the frame.
And in this particular patient, Nico and friends, maybe a high position could be valuable just to minimize or to maximize the chances of recovery of the conduction distance.
So if I understand you, Didier, you would go a little bit higher than where I am?
I think it's okay.
It's okay. Let's record that.
But let's see what the panel thinks about that position.
Yeah, I think this one is nice. Huh? What do you think, guys?
I think if this valve is it don't have the LV shorten of the device part. For me, I think it's quite really good landing zone. So do you expect to make as higher as possible to avoid AV block, or is your standard landing this position? Do you change your landing position instead of the left bundle block of this patient?
So this is a very important comment. So I have to say that pacemaker is not an issue so important that you would compromise the safety of the procedure with a higher risk of embolization, pop out. And second, you may prevent a redo procedure in the future if we are too high. So I do believe that pacemaker conduction disturbances per se are not enough to promote higher and higher implants, because there may be a cost to pay if we think about redo procedure. Not for this patient, but in general.
So let's
follow
go
you.
for deployment. The sequence is the same. Don't worry. We leave the pigtail in place, gelled. It's not what we forgot that. It's our practice also here. So pacing on. Okay, pressure down is okay. Injection. Okay, you can go, Didier.
Okay. So I go very slowly because of the calcium.
Yeah.
So it doesn't move. We have that. Okay.
You have full volume here.
Here I am.
Okay. And pacing off. And you can come back to 80. Yeah, it's okay.
Et tu peux aller le voir pour sa main. Voilà. Merci.
Okay, Didier, I think we can withdraw the balloon. Yeah, the pacing sequence was a little bit long for the patient. It's okay, Didier?
Yeah. So let's leave the wire in place. Withdraw the balloon.
So let's have some comment from the panel about the landing, because you have a big experience
and I'm going to play
in
it again
this
for you.
device. That means that you are as higher as you want. For me, I'm more conservative in this case. I meet more in the LV. Let me ask Helene, Flavio, Matthias, what about the landing, and if this left bundle block affect the depth of the implantation?
Well, I agree with you, Carla. If it were an ultra valve, I would have gone a little bit deeper in the LV. I think the guys are trying to be very high because it has been shown that this valve has a much higher rate of pacemaker, so you have to be more precise in the implantation. And perhaps this is facilitated by the fact that it has less foreshortening. But as I say, personally, I've never implanted this valve. I have just seen that indeed the foreshortening for what is the equivalent of an Edwards 23 is a little bit less, so the implantation that they decided to do is perfect, despite the fact that I was feeling like you that it was a little bit too high.
Yeah, maybe to comment on that, Flavio, and I share your comment on the fact that if you interpret this position thinking that you're about to implant a sapien valve, you're probably too high. But this is the feature of this device, and not to have this the same amount of foreshortening in the inflow portion. And I would say basically for this device, it's a standard initial positioning.
So it's exactly that. I couldn't agree more. We need to switch our mind, our way of thinking. This is a different device, and it doesn't foreshorten the same way. So it's really stable. It expands where you want it to expand, and that's with a minimal foreshortening. So while we are applying the maximum volume, you can see that if you look at the non-coronary cusp and the calcium, the remaining contrast and calcium, the device foreshortens like 1 millimeter. So it's really, I call it the accordion effect. Yeah. So you extend without foreshortening the device, and I like it. So you extend like that from the non-coronary, the posterior aspect of the anatomy to the anterior aspect, but you don't lose height, and that's very important.
So Didier,
and I have to disclose something, Nico.
Yeah, of course.
In fact, and to you guys, the patient wasn't paced, in fact, or because we had I had disconnected the pacing system, and you can see that first he did recover his sinus, his spontaneous rhythm, with the same left bundle branch block, and we have to potentially that high position is going to help.
So let's have a look at the outcome, the way we assess the outcome in our routine practice. It's a 2-modality assessment. Angio and hemodynamics. So here, hemodynamic, we basically, in order to assess the outcome and the amount of PV leak, we rely on the difference between aortic diastolic and LV and diastolic pressure. This difference is quite high here. So it's encouraging, but we know that this hemodynamic index is not specific at all or not enough. So we had this second tool that is the angio. So let's record an angio also here. and see what we get.
So I like it. You first the depth. The depth is exactly where we wanted it to be. So
great,
you can
great
really
result,
tailor the
great
depth.
result.
Yeah, so that's important. Second, well, as I said, regurgitation is not honestly an issue.
Oh, it's a mild error.
New generation TAVI devices, whether it's be self-expanding or balloon-expandable, it's okay.
We have a question here from Matthias.
Yeah.
Yes.
I have a question about the foreshortening. This behavior of this device is the same of the classical Myval, because here in Latin America we don't have Octacor. We have the classic Myval, so the question
it's different.
is...
It's different.
It's different. So
it's different. It's much more predictable, I would say, because it's unique in its construction architecture. So it really stays where you want it to be, and it doesn't foreshorten the same way.
Can you show us again the markers?
Yeah. So let's review it together. You see this marker just at the level at the annulus.
Yeah, slightly, maybe 1 millimeter above.
Yeah,
but,
and it's true that if you focus on the behavior of the stent frame during deployment, you see this the feature we're just commenting now for a few minutes.
Yeah, you see the top is stable. The inflow portion is stable. Then, as I said, we had to apply a gradual expansion. So we had that hourglass shape during one of the initial phase of expansion, and then everything was stable. I didn't feel too much pressure, so I applied the full volume. So.
Didier, one question for you, because it's the second operator that feels that sometimes in that context, based on the calcification we've seen, and fearing potential mechanical complications, sometimes where you don't put all the volume when you feel a resistance. Do you feel that here?
Yeah, I didn't feel that, but I think it's a very important message, Nico, that two steps inflation, dual step with a progressive first part, and then if you are happy, you gradually administer the nominal volume, the entire content of the balloon. But I didn't feel much resistance here, and so it makes sense because the leaflets weren't extremely calcified.
Okay.
And I did pay attention to the way the foreshortening was going to the device was going to expand in the LVOT.
Okay.
Because sometimes when you meet calcium, it stops the progression of the expansion. It stops the expansion, so you can anticipate a potential complication.
So let's proceed now with the
We have here
closure.
a question from Dr. Dumonteil.
Montre-nous ici.
Just one short question for you, Didier and Nicolas, and thanks for this very elegant presentation. So to highlight again the beauties and benefits of these intermediate sizes, so you went with the 24.5 device at nominal volume, am I right?
Exactly.
Okay, and you achieved this beautiful result without residual leak, without gradient. So I think this is very important because you decrease the need of post-dilatation when you have these intermediate sizes regarding when you use smaller sizes for this calcified annulus when you were afraid of the risk of some damage to the aortic annulus. So this is really beautiful. Thank you.
Thank you, Hannibal. So let's go for with a closure, Didier. So you can now focus on the right groin. Okay. So the procedure is now to withdraw the sheath, pull on the prostyle string and tighten the knot.
Yeah. The angels.
Having the 035 wire gelled, so still we have some small bleeding, and what we're doing just after that is inserting an 8-French collagen plug device, angioseal, and assessing the residual bleeding around that. In case we have significant or important residual bleeding here, we can withdraw the angioseal and add another prostyle if it's okay, or if it's very, very important bleeding, we can go with a manta or something else.
Yeah.
Here, we don't have residual bleeding, Didier, so it's okay. So we can proceed with the collagen plug implantation, withdrawing the 035 wire. Okay, if you can cut it, Didier, for me.
Merci.
Let me ask some questions to the audience and to the panel regarding this type of technique. How you close your devices, these 14 French devices? One prog-light, one ancho seal, two prog-light, only one prog-light? You have any comments? Martin, Helene?
In our institution, we prefer to use Manta. So we use a Manta. It's very easy and very effective.
Only one device.
At the opposite, in Rouen, we use either two prog-lights, or when the vessels are quite small, like in small ladies, we do the same, one prog-light and one Manta. Because sometimes there is, and one angioceal, because sometimes there is a small stenosis after two prog-light when the vessel is quite small.
Yeah, exactly, Helene. It's the reason, I think, why we shifted from two prog-lights to this strategy. And we observe less stenosis related to that. And the way we control the outcome at the end is that, and with echo, we check for good flow, no residual bleeding. Of course, we are not experts in vascular echo, so in case we have any doubts, we come back to the routine angio assessment. But looking at what we've seen, it's a good outcome for us regarding the vascular access. So this is what we wanted to share with you regarding this patient. Maybe Didier, a few words to summarize what the important learnings of this case.
Sure. So first of all, I wanted to congratulate Nico, Melody, Céline, and the entire team for the good job, and you for the comments. So what did we learn all together today? So I think we learned how to streamline a TAVI procedure, transfemoral TAVI procedure in the contemporary practice with a contemporary device. I really much enjoyed the discussion that we had concerning the device type and size selection, and it was a good demonstration that we may use balloon-expandable platforms even in calcified anatomies, because the risk of annular rupture may be prevented by these intermediate sizes. So it tells us that we need more devices, and we need to really be able to tailor the device type and size to the particular patient that we have treated. We also discussed how to manage conduction disturbances. This patient already did recover, but we're going to see how he behaves in the future. But my guess is that he is not going to require a pacemaker, but this is a concern that we have. And I also enjoyed the discussion about the height, the depth of implant in regards to this risk of conduction disturbance without preventing or jeopardizing a redo procedure in the future. Because if we are extremely high, the risk of neo-skirt and the coronary risk plane is going to be extremely high in the future. So we need to integrate that. So thank you for your comments. That was my main take-home message. So the floor is yours for the final words.
Thank you very much, Nicolas, Didier. Thank you very much for sharing with us your experience and for this great case. Thank you very much.
Thank you, and have a good meeting.
So let's continue to the end of this session. We are going to introduce Patrick Serruys, Professor Serruys. He is going to talk about Larman trial and have some few words regarding Alain Cribier in his relationship during these last years. So thank you, Patrick, to be here. Thank you to have this long trip to Buenos Aires. It's a pleasure for us.
Thank you, Carla. So we will going to talk about the landmark RCT and Octacor. This is pictures in Rouen in May 2022 at the celebration of the 20 years of TAVR, TAVI. And the next will be a video record for the structural summit in Sao Paulo on 27 of February 2024. And Alain left us on the 16th of February, and Alain Cribier was supposed to be present in that structural summit in February in Sao Paulo.
Alain Cribier has left us. When I heard that last Friday, I was first shocked and then sad. Also for me, it came unexpectedly, since for the last 12 months, we have been working together every week on a new textbook on TAVR that will be his last written legacy to the field. When listening to the worldwide media announcements of his death, you will read, you will see, you will hear continuously the same words. Number one, he was a courageous innovator with a vision and obsessional perseverance that creates something that has irreversibly changed the world of interventional cardiology. Beyond the courageous innovator, you have a caring physician with empathy for his patient wherever the continent he was working in as a tireless teacher. And finally, everybody described him as a gentleman and a humble giant. That's how he will be remembered. I met Alain in 1982 in Rouen when he asked me to introduce the intracoronary streptokinase for his STEMI patient, and he paid me back in a spectacular way when he came to Rotterdam in 1986 to teach me how to do balloon valvuloplasty, and he came back to Rotterdam in 2004 to teach me how to do an antegrade percutaneous valve implantation. Probably one of the last one he did before starting to do the retrograde approach. He was a very talented individual, not only in the cath lab, but also behind a piano. Before getting involved in medicine, he almost made the decision to become a professional classical pianist. And during the celebration of the 20 years of the first valve implantation in Rouen, he gave a wonderful example of his virtuosity playing Beethoven. If he would have not left us, probably he would have been nominated as Nobel Prize in Medicine. But knowing his legendary humility, he would have said that he didn't deserve it, but in my mind, he deserved it definitely. I'm sure that today and tomorrow, he will be hovering in your meeting room during the Congress. I wish you, he wish you a good meeting.
So that's the book that we have prepared. It will be public on September 12th, together with Helene Eltchaninoff, Eberhard Group, Rashmakar, John Webb, and Marty Leon. And you see the other facet of Alain. That's the pictures of 1967, the virtuose young pianist playing Chopin Fourth Ballade. So today I have to talk about the landmark that was performed in 31 sites in 16 countries, and in one country in South America, Brazil, with Fausto Ferres. I had the privilege to be the chairman of this trial, and a lot of analysis was performed in Galway, in Ireland, for the echo, angio, and CT. It was published at the time of the PCR in the Lancet. And the study is a prospective, randomized, multi-center, open-label, non-inferiority trial patient with severe aortic stenosis requiring TAVI as per the 2021 ESC-EACTS guideline. We randomized 1-to-1 768 patients, 384 to the Myval transcatheters series, and the other to the contemporary Sapient and Evolute, also 384. Primary composite endpoint as per the VARC-3, which is very demanding at 30 days, non-inferiority of safety and effectiveness outcome. So we have the result of 30 days, but we will present the 1 year and then every year up to 10 years. What you see here is what is quite unique with the Myval series. That's the only valve with intermediate size. And you see that the Myval and the Octacor, we had 32 in the trial, can range from 9 nominal size, 20, up to 32. While the Sapient 3 and Ultra was only 4 nominal size, and the Evolute R, Pro, Pro Plus, and Flex also 4 nominal size. If you look in terms of annulus area, you can go from 270 millimeters squared to 804. In the trial, the extra large was nested in the registry. And I have to mention that in the Evolute technology, the investigator did not use the 23. The Octacor is new. I heard that it's not yet available in South America. It's made of octagon, not hexagon. And as you could see, the struts are interlaced, so you have a very strong columnar strength. There are only 2 rows, one which is to give access to the coronary artery, and the other to minimize the, is a closed row, minimize the aortic regurgitation. There is a bovine tissue with an anticalcic solution. You have this interesting rhombus of these interlaced octagon for the columnar strength, and you have an internal and external PET to reduce the paravalvular leak. So that's all the dimension that you have seen. What I have to say is that the Life Octacor has a foreshortening of 19 to 20%. That was asked during the case. If you compare to the Medtronic, which is 44%, Edwards Sapient 3, 26, 27, Life Classic 21, 24, we have now a foreshortening of 19 and 20. This small foreshortening is leading to precision placement, accuracy of deployment, lower paravalvular leak, and probably lower pacemaker implantation. So the number of intermediate size used in the trial are in the box. In red, you see the Sapien. You have only 4 size, conventional, every time with a jump of 3 millimeters, and in the case of Evolute, you have even a jump of 5 millimeters between the 29 and the 34. What is remarkable for the Myval is these 9 nominal size with overlap, and then a small step of 1.5 millimeters, which facilitate the selection of the operator. As a matter of fact, before the trial in the observational studies, Muchball, Kawashima, which is our study, Alain and Octacor, we had already a 45-50 proportion of intermediate size. And in the landmark trial, it was already 48% for something new in a trial. In terms of sample size calculation, the hypothesis was non-inferiority to contemporary Sapien and Evolute for primary combined safety and effectiveness endpoint at 30 days. The assumed even rates according to the VARC-3 is 26.1%. The non-inferiority margin is 10.4%. The one-side alpha 5%, and the power quite high, 93%. So altogether we need 768 subjects. The VAR3 is a composite of all-cause mortality, all-stroke, bleeding VAR3 and 4, acute kidney injury stage 2, 3, and 4, major vascular complication, moderate or severe prosthetic valve regurgitation, conduction system disturbances, resulting in a new permanent pacemaker implantation. As you see, we are still dealing with octogenarian. What is good is 50% male-female. You see the syncope in 6%, syncope not related to AV block. Hospitalization for symptom of aortic stenosis in the last 6 months, 14 and 18%. NIA classification 3 and 4, around 50%. And angina pectoris class 3 or 4, about 8 and 7%. The STS risk score is low. The median is 3. 75% is a low score below 4. 20% between 4 and 8, and 4% above 8. If you look at the medical condition and medical history, and I've been ranking that by order of incidence, you see hypertension, filtration rate less than 60 ml, diabetes, smoker, a history of atrial fibrillation or flutter, glomerular filtration rate less than 30, and then a few coronary artery, COPD, and other comorbidity. In terms of echocardiography, we were looking with the collab to the mean gradient, 40, the peak gradient, 65, the peak velocity, 4 meters per second, the aortic valve area, 0.7 centimeters square, good ejection fraction, no pulmonary hypertension with a peak systolic pressure around 34. In terms of multi-slice CT scan, the aortic annulus area was in both groups 471 millimeters square. The aortic annulus perimeter, 77 millimeter, and it is interesting that almost 1/3 of the patient has a small annulus with an aortic annulus area below 430 millimeters square, and bicuspidic was allowed in this trial with small percent of 6 and 7.5%. So what you see on this slide is the probability plot. The dash black line is equivalence between the primary endpoint. But as a matter of fact, the Myval has in a Gaussian distribution less composite endpoint by minus 2.3% when compared to Evolute and compared to Sapien. Then you see the upper one side confidence, 95%, which is far below in red the non-inferiority margin at 10.4. In other words, we reach the non-inferiority with a p-value of 0.0001. Now, if you look at the numbers, it's 24.7% for the Myval and 27% for the Evolute Sapien with 94 and 103 event in the non-inferiority. If you look at the detail, you see that all-cause mortality was equal, 9 and 9, all-stroke equal, 12 and 12. In red, you see a small advantage for the contemporary series in terms of bleeding type 4 and 3 and 4, and acute kidney injury stage 2 and 4. But then in favor of Myval, we have less non-significant, but less numerically moderate prosthetic valve regurgitation, less new permanent pacemaker, and less major vascular complication. All the valves go to a struts of 14. Now, what is interesting is that if you look on the vertical axis to the effective orifice area of the Myval, you see for the 7 nominal size, the value increasing from 1.42 to 2.43. And if you compare in red to the Sapien series, you see that for the 20 millimeter, it's the same orifice area, but then comparing for the 23, 26, and 29, systematically the Myval has a quite large effective orifice area and systematically significant with a p-value of 0.01. Now, if you look at the evolute, and I told you that the only comparable nominal size is 26 and 29, you see that the Myval is seriously competing with the self-expanding. So this is the global pictures. Now, I'm finishing by the fact that not only we look at the nominal size, but we look also at the post-procedural effective orifice area in centimeters square versus on the horizontal axis, the pre-procedural aortic annulus area. And you could see that for the nominal 20 millimeter, there is basically no difference between Myval and Sapiens, although Myval was implanted in vessel in orifice area less than 300 millimeters square. But then for the 23, there is again a significant advantage of the Myval, similarity with evolute, but for the 26, again, advantage of the Myval, and the same is true for the 29. Now, my friend Prof. Axel Link from Germany suggests a fitting index, which is something new. What you do the ratio between the nominal size in diameter of the valve versus the aortic annulus diameter. And you could see that in this case, derived from the area, the diameter is 21.1 in green, derived from the perimeter is 21.4. And at the bottom of the slide, you see the fitting index, which is close in this case to 1.02 and 1. Now, on the left-hand side, what you see in green is the fitting index for Myval. In red, the fitting index of Sapien, and in brown, the overlap between both. To make your life easier, I present that on density curve of fitting index of Myval and Sapien series. And as you could see, below X, there is no overlap between the two. Between X and Y, there is the same similar fitting, and above Y, again, there is no overlap. And there is already, with this small number, a consequence of the pacemaker. Below X, you could see that the pacemaker of the Sapien is 20% versus 12.5% for the Myval. When they are both fitting, there is no difference in pacemaker implantation, 15 and 14.1. And again, there is a small difference. All of them are not significant at that stage, but don't forget that in London Valve, we will present the big trial systematically of Sapien versus Myval and Octacor. So this is something we have to pursue about the fitting, the fact that when we are in the lab, we can select it by 1.5 millimeter the valve that we want to give. And you have heard, Didier, you want to avoid a few cases of ruptures of the aorta, which is really dramatic. So in conclusion, the landmark trial is the first head-to-head trial comparing two balloon-expandable valve and one self-expanding valve based on VARC-3. The landmark trial has expanded the indication of TAVI to those with complex anatomy, such as small annulus, less than 430 millimeters square. I'm just coming back from Japan. The Japanese are very, very interested by that subgroup, and bicuspid aortic valve, which is very common in the Far East. The landmark trial established the non-inferiority of Myval series compared to contemporary for early safety and effectiveness, composite endpoint at 30 days. When the effective orifice area of conventional nominal size 20, 23, 26, and 29 are compared, Myval show even for the 20, but significantly larger effective orifice area for the 23, 26, and 29 than Sapien and similar to the effective orifice area of the Evolute series at 26 and 29. The availability of the intermediate sizes enable precise and appropriate matching of devices to an individual patient anatomy and was used in 48%. Continued follow-up to 10 years will unravel whether document effective orifice area of the Myval will have a beneficial impact on the long-term patient prognosis and valve durability. And as a last slide, I would like to thank the fellow of South America who helped me in the past, Marco Costa, Mariano Arbeltal, Nestor Mercado, Pedro Lemos, Gaston Rodriguez Granillo, Hector Garcia Garcia, Carlos Campos, Moro Echevarria Pinto, Rafa Cavalcante, Carlos Colle, and Rodrigo Modelo. And you could see that they all have a PhD coming from Europe. Thank you.
Thank you very much, Professor Serruys. I would like to have some words from Dr. Revicini. Thank you.
Thank you. Thank you, Diego. Thank you very much, Professor Serruys, for sharing this very interesting data. Of course, I think that one of the main points that you made is this comparison of the effective orifice area, which, despite being, as you can imagine, the same valve because it's a balloon expandable, has larger values compared to the Edwards valve. So this is very interesting. It seems to behave more like a self-expandable because you've shown that there are no differences with the Evolute 2629. So I have two points to discuss with you. I want to know your opinion. Is it in the protocol? Because as we have seen recently in the live case, the Myval requires pre-dilatation in all cases, and this is very seldom performed with the Edwards. Do you have the data of pre and post dilatation? Is that the explanation? And the second point is, you have shown the effective orifice area, but we didn't see the final gradient. And to make a comparison, for instance, with the SMART trial, that gave very clear differences in between self-expandable and balloon, it would be interesting to see the final gradient, which is also an important parameter to compare. Thank you.
Flavio, that's a lot of interesting question. I think that we were surprised to see that superior effective orifice area, which may at 30 days makes no difference, but could make difference at 5 years of 10 years. Look at the story of Partner and the Evolute. Because a valve which is opening more is basically a good guarantee for durability, and that's probably very important, and also strain and stress on the leaflet. I think that the United States has already a very large experience in Resilia, and Resilia has been published in the JACC intervention. You can see in JACC intervention the pictures of the valve Sapien conventional and the Resilia, and everything is in the attachment of the commissure to the metal, which is much thinner, and that's the reason why the valve opened more perpendicular to the struts of the valve. So we will have to work on the long-term follow-up to see if something emerged in terms of fatigue of the leaflet and durability. But I think your question is a very good one.
So thank you very much, Professor Patrick Serruys. I think we have another session in this meeting to talk about more about balloon-expandable devices and Myval 1. So let's reach the center of the ASIN because we are going to have the last part of the session. Voy a pedirles a todos, por favor, si se pueden poner de pie, y voy a pedir a Martín y a Helene, Profesor Helene Eltchaninoff, a Profesor Martín Gillard, que se unan conmigo al centro acá de la pantalla. Como ustedes saben, esta sesión es en tributo de Alain Cribier, quien fue muy importante en mi carrera, igual que Helene y Martín. Todos mis fellows lo adoran siempre, lo siguen nombrando e hicieron un video para él durante este minuto de silencio. We are just saying that what are we going to do right now? We are just listen and watching a video who memorize Alain Cribier. It's an homage, it's a memory from him, and we just end the session with 2 words from these 2 colleagues. So let's play the video, please. ¿Podemos pasar el video, por favor? So, just 2 words, Helen, because I think I want to don't be too long this part of the session. Just mention how was Alain for you? Was Alain for you as a mentor, as a guiding in the cath lab? What is your vision? What was Alain in your life?
Thank you, Carla. First of all, I wanted to thank you to having organized this session with your colleagues, with the committee, because it's always very emotional to see these pictures, and I know how you are part of, Alain is part of your life and of what you became. So for me, in fact, I came to Rouen because in Paris, they told me that there was a crazy guy working on something new, on a balloon. So already at this time, that's what I heard from him. And then when I came to Rouen, I was really fascinated by the number of physicians coming from abroad, by the number of patients coming from balloon dilatation, and this fascination to this new world, in fact, was coming just for one man, from Alain, and that's why I decided to become an interventional cardiologist, to try to become like he was, because he was combining, in fact, everything. He was making rounds with patients, always beloved by all these patients, taking time to explain everything. He was an excellent interventional cardiologist, not only in valvular disease, but also in coronary disease, having always plenty of ideas. He was an excellent teacher because as soon as he understood I wanted to be an interventional cardiologist, he took me in the morning at 8 a.m. to teach me himself how to perform angiography and then all the following steps. And he was also, as you know, an excellent trainer for all the fellows who are coming to our department, always leaving room to them to try to work, never keeping for himself all what he experienced. So for me, after that, I became, in fact, his right arm, and I had the chance to participate to all the adventure with him for more than 35 years. He was always pushing me to go ahead, to proctor in different places, to participate to meetings, to committee, and always trying to make me, in fact, better. And for all these qualities, for what was said by Patrick Serruys, his humanity, his joie de vivre, he loved to make parties, also very one. Of course, I miss him very much, and we miss him a lot.
Thank you, Martin. A few questions. Just, it's not very common to see 3 females interventional cardiologists in the screen, you know. How find that type of mentor? Because it's one time in a life, or how the people find mentors?
I think thanks for this great session. And for me, a mentor, Alain is a great mentor because he is so empathic, so humble when we transmit the information. It was very like your friend. Is not, and this is for me a very important quality of a mentor. And also for the diversity, for the equity. For Alain, gender is not an issue. You are first an interventional cardiologist and then a woman or a man. And I think for me, a mentor must be like that. No take care of the gender, just take care of the ability of the fellow to become an interventional cardiologist. So this is a great quality of Alain. And for me also a mentor is like Alain, is with always smiling, no huge. I think it's very important to be like that, very empathic, very generous, very with a light, a bright smile, and a huge sense of humor. It's important because when we make face of a difficulty during your career, the mentor can help you and say, okay, don't be afraid by that, go on, and everything will be better. So I think for me it's a very huge quality of mentor, and for me Alain is a mentor.
So thank you very much, everybody. Gracias a todos por esta sesión. Creo que vamos a terminar aquí. Quédense para la próxima sesión, que es un caso en vivo, y sigamos viendo en este congreso que parece que va a estar buenísimo. Gracias a todos.